In conversation with Koye Oyerinde, Koye Oyerinde, MD, Doctor of Public Health, is a pediatrician and health policy expert. His more than 30 years of experience include stints as a medical officer, pediatrician, health policy researcher, and teacher. While on faculty at the Mailman School of Public Health, Columbia University, USA, he provided technical assistance to more than 30 national ministries of health in the Global South and maternal and child health service delivery. For 6 years, Koye was a member of GAVI Independent Review Committee. He was until recently the Policy and Advocacy Chair on the Executive Committee of the Section on Global Health of the American Academy of Pediatrics. Learn more at drkoyeoyerinde.com. And on today's episode of Author Interview, it's my utmost pleasure, joy, and excitement to have on the show today, Koye Oyerinde. Welcome on the show, Koye. It's nice to have you today, really.
Thank you very much. I'm happy to be here.
Yeah, I'm very excited, really, to have you. I was intrigued, first of all, discovering your website and checking your books on Amazon. The title is quite compelling to me. I'm excited we're here to talk about it. Thanks for coming on.
Thank you.
Yeah. So, Koye, I need to say that I was impressed when I read through the description page of your book, Who Should We Let Die? How Hate for All Failed and How Not to Fail Again. I would like us to start with the many obvious questions most authors get asked. What inspired you to write this book?
Well, for a time, I was a college professor where I taught public health to graduate students at Columbia University. My students were largely American students and a lot of African and Asian students. And they always wondered why I had my kind of unique answers to their questions about health services around the world. Well, my background, my experiences inform my approach to health policy, and the book is an attempt to answer many of their questions about why I have such unique solutions to these problems that plague health services around the world.
That's amazing, really. That's quite beautiful to know, yeah? And I need to say that I love the title, Who Should We Let Die? It talks a lot about the heaviness of the content in the book. I'm just curious, how did you select the title? Did you have another title in mind for the book initially? If yes, how were you able to select this out of the other ones you initially had?
Yeah, as most authors will know, the title, I don't think you ever start with the final title. You kind of have a title in mind of what you want to say.
Yeah.
And my title was mostly about health for all, but it sounded just bland. And and the question is, who really wants to read about that?
Yeah.
And in the course of writing the book and working with my various editors, I had to come up with a final title. And they were asking, what's the title going to be? What's the final title going to be? And I had to, and one day I was just thinking about it, that at the very heart of what I'm writing about is healthcare. But what's the point of healthcare? The point of healthcare is to keep us alive. And if you look through the book, one of the things I write about is how healthcare is paid for. Mm-hmm. So when you have a child with a severe illness and the parents are poor, are we supposed to let that child die because his parents are poor? If I have a bad toe that's infected and I go to the ER or the emergency room and I don't have money, should they just send me home without treatment? In many countries in the world, particularly in Africa and South Asia, if you don't have money, you go away. It's a cash and carry system. You pay cash, you get the services. That means we are saying effectively that if you don't have money, we don't really care. You can go home and die. In the US, I talk in the book that the US healthcare system is a GoFundMe healthcare system.
Mm.
Because in the US, we still have families going bankrupt because a member of the family is ill. We still have people having to sell their property to pay for healthcare for somebody in the family. And if you go to the GoFundMe website, of all the advanced economies in the world, it's only America that more than half of the people on the GoFundMe website are there to essentially panhandle for money to help them pay for the healthcare of a family member.
Yeah.
Well, that's totally unacceptable in the richest country on the planet. It's totally unacceptable in the 21st century that we cannot organize health services in a way that everybody is covered.
Mm.
And so it's those kinds of questions that led to the title, that if we are not providing healthcare services to all, then we're saying to some people, you should just go and die. So we asked the child of a poor parent, should he go and die? A poor pregnant woman who cannot afford a cesarean section,
Mm.
what are we telling that mother? We're saying, sorry, you don't have money, go and die. What are we saying to someone who is disabled and unemployed? We're saying, because you're disabled and unemployed, well, we don't really care, go and die. So that's the point of the title. Who should we let die?
Yeah.
And if we ask everyone, I think we will all agree that we shouldn't let anybody die. And if we agree with that, then the way we are running health services in most of our countries is wrong. Health services should be prepaid so that at the point of care, you don't need to bring out money. So if, as I sit here, I have a toothache, I don't have money kept away for my toothache. I wasn't planning for a toothache.
Yeah.
Yeah, so I should be able to go to some place to have my toothache handled without me having to bring out money right now. Ideally, it should be paid for by a pool of money that's been collected beforehand. And then, I might have to backfill if I have plenty of money. Okay. On the other hand, if I'm extremely broke, unemployed, can't afford to pay, I'm retired or I'm disabled, I can't afford to pay, well, then that pool of resources should be large enough to pay for my healthcare services. So for those who are extremely wealthy, okay, maybe you pay something for your healthcare.
Yeah.
I'm paying to the pool because you have plenty of money. But, even those who are extremely wealthy, at some point they might get retired and they're no longer earning money. Well, they might need support at that time. Exactly. So that's the whole idea that I'm trying to move in the book.
It's quite a beautiful one, really. Quite compelling. I was taking some notes while you're speaking, and I think you've got a good number of interesting questions in there. Especially, I love the fact that you mentioned that, because this is something that is very predominant in Nigeria, for instance. I've been to hospitals, I've gone to, even myself, yeah, we've had an instance in the past whereby if your people are on the point of death, yeah, but if you don't have money to pay, there's no way they're gonna, there's no way they're gonna treat you. We are sorry, but we need money to buy most of the things required to do all of these things. And I actually think it's quite wrong, really, because most people have, because of this, passed on. They've died. You see mother trying to run scatter, trying to get help, borrow money from one side to another, trying to run to a church. I have been in this situation before in the past, yeah, which is I find to be very, very quite relatable, yeah, because it's something that is very predominant. And that reminds me of a particular book I read in the past. I cannot remember the title currently, of a similar situation whereby I forgot the name of the man. I remember during the course of the conversation, where it was basing his healthcare system on, come, I'll treat you first, then once you're healed, then you can make a payment later. Then another one was based on insurance basis, and it is quite very different. And this is something that is really needs to be addressed. It needs to be addressed in the government status, in the political stage, in the federal level, because this is something people are actually going quite. We've had so many, especially during there's this. I don't know if you know about this. Sorry to take you much longer, yeah, but there's this time where we had cash scarcity in Nigeria, whereby we have an issue with the CBN not being able to produce the money, and so many people died in the hospital because they cannot get the money. They have the money, but they cannot withdraw it. You think you're like, oh no, no, we don't use this. We are going with a new note, and we are going with that's a different scenarios. But aside that, so many people have died in the case of not being able to afford, medical bills at the time that they are sick, because nobody actually know you're gonna fall sick. And that's why the conversation of going for medical checkups come to place. And so many actually. I love your take on this. It's quite beautiful. It's a deep one. It's one that you can keep on going from one part to another, talking about really.
Yeah. So one of the things we have worked on in the past, there was the Abuja Convention, in which all African leaders, for example, agreed that health is a human right, not just healthcare services, but health is a human right. And when we say health is a human right, what we are saying is that that gives me the power to fight back if a factory next to my home is polluting the environment. Then I can talk to my leaders and say, if you're saying my health is a human right, why do you allow the Lagos Lagoon to be polluted? So when I eat fish from the Lagos Lagoon, I'm actually eating a lot of mercury, a lot of other pollutants in the lagoon.
Yeah.
So when we say health is a human right, which is the agreement of all leaders of the African Union,
Yeah.
well, then the Lagos state government must go after those who are polluting the Lagos Lagoon.
Yeah.
And tell them, no, you cannot pollute this lagoon because people are using it for recreational services, for food, for transportation. So you have to protect that lagoon and make it clean. So don't dump all your chemicals from your factories in Igomu into the lagoon. Right? So those are the kinds of thinking behind when you say health is a human right. It's slightly beneath that level is when you now talk of healthcare services.
Yeah.
So as a government, we have to organize healthcare services in such a way that everybody within my state, everybody within my country is covered one way or the other. And, you know, in several forums I've been to, people have said, how do we pay for it? How do we pay for it? Well, you have to pay for it in interesting ways. One of the ways I recommended in the book is that we have inherent rights as human beings because you are born and you're alive. So you as someone who is working takes something out of your income to cover your health care.
Yeah.
If I were to work for a company that is highly risky, let's say a miner, so I have to go down 2 miles to scoop out coal. That's a highly risky endeavor.
Yeah.
So my employer needs to pay something for my healthcare beyond what I pay for my own healthcare.
Absolutely.
So that's how we're going to put all of that in one huge basket. The employers of labor. So if you are just a teacher, your high school, so what's the risk here? They might put you on a scale of 1 or 2 or something like that. If you are a deep sea diver, that's a highly risky endeavor. So then we'll put you on a scale of like 10 or something.
Yeah.
So the amount your employer pays for your healthcare goes high up if you are doing a highly risky business.
Yeah.
Whereas if you are just a classroom teacher, the amount goes way down. Then because you earn an income, you pay something for your healthcare and the healthcare of your children. And then the federal government or state government takes out taxes for everyone for healthcare purposes.
Yeah.
So in the end, if someone gets knocked down on the street by a taxi, we don't have to think, where's the money deposit before we touch you in the hospital? We know he's a citizen of the country. He lives here. There's somehow to be able to pay for this. So we're not waiting to say, here's a list of things to go and buy. The guy has a fractured skull. Who are you going to give the list to? He was knocked down on the streets in Lagos. Nobody knows who his relatives are yet. But when you take him to the hospital, they'll say, where's the deposit for this one first? Well, he was just picked up by bystanders. So who's going to pay for that deposit? The poor guy gets dumped in one general hospital somewhere and people run away. And then even there, nobody touches him because there's no money to take care of his health care.
Imagine.
That's not how to run health services. Part of what I write also about in the book is emergency services. Emergency services are not a luxury to add on when we get there someday in the future. Emergency services are primary care services when we're in trouble, right? So I ride a bike, I fall off the bike, I break a knee or break an ankle or something. That's an emergency right there and then. I can't go to my GP. I can't go to my family doctor. Right there and then, my primary care service is my ambulance that comes to pick me up there and takes me to the ER.
Yeah.
Okay. In most of our countries, you cannot call for an ambulance in Nigeria to come there in an hour.
Yeah.
Maybe it will not come there in a day if you call for anybody to help you with an ambulance. So people just put you on the back of an Okada and they'll drive you straight to the nearest hospital they can drop you in. Well, that's not the way to run health services. There has to be a system by which you have ambulances. We have trained people to man the ambulances. So it's not just a driver that doesn't know what he's doing. Here we call them EMS officers, so the emergency medical services officers who have been trained to do first aid, to do, CPR. They can resuscitate, they can even intubate, they can do all kinds of important things to get you to the emergency room. So that's part of your primary care that has to be there from the beginning of health services. And part of what I hope the book will do is inform our people that when your governor opens a new health center, that you look at him, where's the ambulance that will help me get to this health center? Where's a common number that I can call on my phone when I need to get to this health center in an emergency, or this new fancy hospital you're building? How do I get there? Who do I call when I'm in dire straits? And so it's not just the buildings that are important, it's the system that makes it work. How do we have the hospital services? How do we have the emergency services to get us there? And then how do we cover this cost financially? I mean, the other topical point in the book is about human resources. With all this, everybody wants healthcare. How are we going to pay for it? Okay, who's going to do the work? There's brain drain. People are leaving Nigeria. The doctors are leaving. The nurses are leaving. Okay. First of all, people are not only leaving Nigeria, people are staying but leaving the profession. So when I left Nigeria about almost 30 years now, a lot of my friends who went to medical school together were no longer practicing medicine. Some were just businessmen. Some were selling real estate. Some were doing some kind of import-export business. Some left and went to do accounting and became bankers.
Wow.
So it's wrong to focus only on the brain drain, on people leaving the country. A better approach is to have a more comprehensive look at people getting out of the system, either within the country or externally.
Yeah.
And first of all, I'll say this is specifically now for Nigeria, we need to get more people in medical school to expand access to medical education, maintain the standards. So when I entered medical school, if you scored anything less than like 280 in your JAM, then nobody's going to consider your application.
Yeah.
I think for most schools at the time, maybe like 250 will be like the least anybody will accept.
Yeah.
So I'm not asking us to drop the standard. I'm saying keep the standard. There are enough kids in Nigeria that will meet the standard to be set. Expand access to medical education, to nursing education. And there are also a lot of sub-disciplines that are not very popular, like clinical psychology, like physical therapy.
Oh,
wow. And then even under those, you have instead of a full nurse, there should be a huge program of nursing assistants that are qualified. They're not they call them nurse muyiwa in Nigeria in those days, not those hardly educated ones that we sometimes see around, but a structured program. You get your 5 or 6 credits at the O levels, at the high school, and you go into maybe a 1 year or 2 year program to become a nurse assistant. So those who can afford to spend 3 years away to study as a nurse can do a nursing assistant program, begin to work, maybe go back later to finish their training. So there has to be pathways on the way to where you're going. You can have a pharmacy tech. So they have their full qualifications from high school, but they don't either they don't have the money or they don't have the time for a 4-year, 5-year program to
Yeah.
study pharmacy. Well, they could do a 2-year program and become a pharmacy tech and help with work in hospitals and dispensaries and so on.
Yeah.
Then a couple of years later, they might go back and finish up their program.
Yeah.
Same thing. There are a whole host of ways you could do medical school. You can have like the NYSC core with an additional year to say, well, you know what, we'll pay for accommodation and a little ambulance, something like that, to run around in some local government if you stay an additional year with your youth corps. A lot of people will accept that and say, well, you know, I like the work I'm doing as a youth corper in this village. People are getting services. It's working. I don't have anything lined up immediately for next year. Maybe I'll stay another year, say, as a youth corper. And we'll give you a little bit more stipend because you're no longer a youth corper. You're just staying on, you could call it something like a public health or medical services fellow or something like that. And then you get a little more than you get as a youth corper, but we provide our accommodation and provide you with, even if it's a tricycle, so you can visit all the villages around and monitor their healthcare and do things. And, you know, there are ways that it can be done to get people to stay longer before they leave the country. But you cannot stop people. I've seen a lot of people say, yeah, stop it from leaving the country. No, you can't. They've gone to school, they've studied hard, they passed their exams. Even when they're going overseas, they still have to do exams to survive over there. So they've done their exams over there, they've passed. So now the British want them, or the Americans want them. You can't stop them from leaving. And we cannot compete with them because they're paying good money, much more money than we can pay in Nigeria. So I will actually say encourage them to leave rather than stand in their path. Work with the multilateral agencies, bilateral agencies, and say, DFID, I'm going to give you 200 doctors. Can you then pay us some money so we can upgrade our hospitals and training medical education services and nursing education services? Can you send us some of your students so we have bilateral agreements? So some of your students from the UK can spend time in our hospitals here, and some of our students here can go over there and spend time in your hospitals. So we have to think on a larger scale and say, okay, you're an extremely great surgeon in Nigeria, but you want to leave. Well, we should help you leave rather than stand in your way. But we want you to leave in an orderly fashion, so you don't suddenly leave and there's no other surgeon left. So we say, we're going to help you leave over the next 2 years. There's a hospital in Leeds in the UK that will take you on as a fellow while you're preparing for your FRCS exams or something like that. And in exchange, they are sending us some surgeon who wants to have a tropical experience. So we replace you with this Brit who wants to have a tropical experience. You can go over there in a structured way, so you're not just jumping into uncertainty. And in that way, we can work together. And that's the way we're going to beat this crisis we have with human resources in Africa. Those who are taking our doctors and nurses need to pay some money to help us. Because you see, let's think about it this way. In the US, there are a lot of services that Americans don't want to do. So we outsource those services to other countries. So you hardly find anybody sewing shirts and pants and clothes in America on a large scale. Most of the clothes we wear are from Bangladesh, from Vietnam, from Latin America, and so on. Because we don't want to do those jobs. So we outsource them to countries where they still like to do them. So think about medical education and nursing education. Africa has proven to know how to do it well.
Nigeria particularly.
Nigeria in particular, there are other countries in Africa, Ethiopia, Sudan used to be a great source of doctors for the world.
Wow.
Kenya,
Interesting.
So we know how to garner, we know how to produce good doctors at relatively low price education.
Yeah.
But excellent education. In the Western world, it's very expensive for them to build new medical schools. Even the regulations around access to cadavers, access to patients are so tight that sometimes it's ridiculous.
Wow.
And I speak with kids who have gone to school in Eastern Europe and finished medical school and never touched a patient.
Wow.
And I said, no, that's not medical education. When I was medical school, I touched patients every day.
Wow.
I had to talk to them. I had to touch them, touch the tumor, touch the broken leg, feel the crepitus, the fracture in the leg. You have to, it's a lot of hands-on education we had. And so if we know how to do that kind of good quality education, and up till now, I still have people arriving from Nigeria to take the medical boards in the US. With a little support and coaching, they excel.
Excel brilliantly.
Yes, I have them go to do PLAB in the UK. The little coaching here and there, they excel. Same thing in Canada, same thing in Australia. So if we're doing that well, there's no reason why they can't outsource some of their own medical education to us. So send us some of your kids who want to go to medical school. Let us train them. And bring with them some money to help us expand medical education to other people. So when I was in medical school, about 6, 8 or so kids in my class were not Nigerians. They were from South Africa, from Liberia, from Sierra Leone, and so on. And a lot of my India, Pakistan, a lot of my teachers at the time, we had a Guyanese microbiologist, we had a Egyptian biochemist, Cameroonian chemist. So again, if we think globally, then we can bring the best and the brightest to teach in those schools.
Yeah.
Bring also the students from the diaspora, African diaspora, bring them to those schools so that the medical schools are actually serving the world and not only just Nigeria.
Yeah.
And then make sure the funding then follows these people that come from overseas to study in Nigeria.
Yeah.
With that funding, we build better medical schools, improve medical education, put more resources, more technology into the learning experience of these young people, and create more, enough for Nigeria and the sub-region and the world.
You've said quite a lot in here, really. You've given a trunkload of amazing ideas that I really wish we could have the position or the rulers, the ones in charge of medical association in Nigeria, would sit and hear all of these things. And I think they should actually have an idea of how things ought to work. But I don't know how, I just don't understand how the whole thing is really mixed up. But then you've got a trunkload of idea that got me nodding my head. I was taking some notes in here, and at some point I stopped. I said, let me just sit and listen. This is quite impressive. You've mentioned amazing, it's not just about building and facility. We should also, that are important. The other things are quite important as well. You've mentioned quite amazing ways of collaboration. You've mentioned inviting some of the foreign students to come have education over there in Nigeria. Because even most of these foreign countries rely on international students' fee, tuition fee, because it's quite heavy. Like those guys are paying quite a lot to come in here and get educated. So then when I asked some of my friends, how much do you pay for tuition? And the fee is just quite ridiculous. So I was like, really? That's too expensive. because they're paying
Right.
quite a lot, paying quite a
Hmm.
lot for schools in here. It's I think there's quite a lot to do in Nigeria. There's so many things that needs to be changed, and the stories you've mentioned, and how if you are poor, you don't have money. That's it. Nothing has to be done. We need you to pay before we can sell a service for you. It's not supposed to be that way. We should come up with a much better initiative. And I think this is one of the beauty of public health, informant, public health. You know, so many things really needs to be done. And I appreciate and love your trunkload of ideas. You're quite great, very evocative, worth following, beautiful ideas you've shared in your book. I'm quite excited you're even sharing to this podcast so people and viewers can get to see how things ought to be done, really. It's a lot. It's a lot that needs to be fixed. And I mean, fixing it might take quite, I don't know how long it's gonna take, but I just hope, I don't know, those who are the decision makers, the judiciary, the big boss in charge of things like this. A lot needs to be done. A lot needs to be done. And you've mentioned quite a lot in ideas, in innovations that needs to be done in healthcare in Nigeria, particularly. Thank you so much for mentioning. I can go on and on. This is quite beautiful and quite awesome. Very
Thank you.
awesome. And I wanted to ask you just before we wrap up, yeah, how has the profession as a pediatrician and health policy expert influenced the making of this book?
Well, I mean, I started off in Ife at the medical school,
Mm,
and one of the things that I was inspired by were great teachers who, who at the time pointed me towards health policy. And we had electives. I took all the electives available in health policy.
wow.
A lot of my friends were more interested in surgery, and the more they found it the more interesting parts of medicine.
Yeah.
But for me, I was always drawn to those really dry things that nobody wanted: the biostatistics, epidemiology,
Mm,
uh, health policy, and they obliged me, so to speak. They really opened up their offices and time to inspire me to to go down that path. And well, the health policy doesn't pay much financially. It's not that financially rewarding,
mm,
and so that's what led me to pediatrics.
oh,
Pediatrics is one area of medicine where
yeah.
that's largely preventive. Most of the important work in pediatric is preventive. Unlike because you don't want the kid to fall ill
Yeah.
and they have a whole life ahead of them to live. So that's why in pediatrics, prevention is the key word.
Mm,
Whereas in adult care, people are already old, they already have chronic illnesses. Now you're managing chronic illnesses.
mm,
In pediatrics, we are largely preventing illnesses and trying to stop this kid from getting the disease in the first place.
mm,
And so that's the nearest thing to health policy work, because then you have to think of how do you get vaccines to the children? How do you prevent malnutrition and feed kids who are malnourished and so on? And so that's how I came into pediatrics, and how pediatrics and health policy come together for me in one career, so to speak.
mm.
And I've always tried to inspire every young person who wants to do medicine to try pediatrics and to try health policy work.
That's quite amazing, really. I mean, I love your answer to this question, and I can go on and on and on and on, but because we are running out of time, really, and I just feel this is very beautiful. The answers you've given so far is quite beautiful, and I just remember the name of the man I was trying to remember initially about the needs of not really, basing health care based on pay for service. Yeah, it was Sidney Garfield. Yeah, for Kaiser Permanent, who created the first healthcare plan and changed medicine forever. I think I read that in a book. Yeah, and I was really intrigued by his story and the frustration he faced initially by those who have been in the health before him, who doesn't really want his plan to work. Because I think this is actually something else. We have private we have private hospitals, and
Mhm.
if you are now coming up with an idea that okay, you just come, we treat you, I believe it might be kind of counteracting in how some organization works and how others works. So there's frustration in one party to another, just like we have what's his name? Dangote wanted to create a refinery, and there's a huge pull from the federal government. Oh, we don't want you to do this because we're getting quite a lot from international stuff when it comes to oil. And I'm excited they succeeded really. So these are things again. These are the challenges, the difficulties, etc. And it's quite beautiful. Really, I love everything you've mentioned so far.
Well, I mean, for the private sector, they have nothing to be afraid of.
Right?
They have to step up their game
Mm.
so that those who can afford it will leave the quality public services to go and get the more hotel type services they will get in the private
Hotel
sector,
type, personal.
right? So if you're going to Sheraton Hotel, they're going to come and greet you at the door. There's the doorman. They welcome you in, but that doesn't make a difference to the sleep you're going to sleep that night.
Yeah, absolutely.
Yes, so same thing. If you really want to pay extra, somebody will welcome you into the hospital. There'll be a lovely lobby. They'll give you like a three-course menu for your lunch in the hospital bed, air conditioning, and all that.
Yeah.
All of those things are hospitals, they're hotel services, they're
Mm.
hospitality services,
Mm.
they're not health services.
Oh,
So when you can afford to pay, go and have your hospitality services in the private sector.
yeah.
But the quality of healthcare should not be different, right? If I
Yeah.
want to pull out my appendix, whether it's a public center or a private center,
Private.
it should be the same quality.
Yeah.
But when you pull out my appendix in a public center, maybe I go onto a single bed and I'm under a bed net and a ceiling fan to cool me down
Mm.
while I'm waiting for my appendix to heal.
Yeah.
In the rich man's case, he
I
might go
understand
to
now.
that
Yeah.
place where he gets a water bed to sleep on.
Yeah.
There's some music playing in the
Absolutely.
background, there's air conditioning and all that. Well,
Mm.
those are hospitality services.
Mm. Yeah.
What we should be concerned about in the public system is quality health services.
Oh, and now it can be reached to everybody.
How it reaches everybody.
Yeah.
Now, if you say you're so fantastically rich that you don't want to do public, then you can go somewhere else.
Yeah. You want a private one, yeah?
Go somewhere else for that. Don't get all the welcome at the gate and,
They will treat you high
kind
five-star,
words.
5-star standard.
Exactly. You get your 5-star over there. But let the rest of us get our 2-star quality here.
Yeah, let's the public guys do that. Honestly, I think quite a lot needs to be done in Nigeria. And I really enjoyed this conversation. It's quite beautiful, very wholesome, and I can go on and on with it. Really, thank you so much. Just in case we have some viewers who are currently watching, I would love to get a copy of your book. On what platform is it available on for purchase?
Well, it's available on Amazon. And for those who care, they could go to my website. It's www.drkoyeoyerinde.com. And there they can, if they use the contact form there, they can reach me and get a discounted signed copy from me.
Interesting. That's great. That's great. And I left a link in the description part of this interview where interested viewers can get a copy of Koye Oyerinde's book directly on Amazon, on Barnes& Nobles, on his website, and also on other platforms. I also left links to his social media pages for possible followings. So thank you so much, Koye, for accepting the invitation to be featured on P English Literature. And most of this conversation is more than awesome, very great, quite educative, impressively heavy, and wholesome, and I enjoyed it thoroughly. Thank you so much for coming on, and thank you so much for an impressive conversation.
Thank you very much for having me. Thank you.
Yeah, it's my pleasure as well.